Thank you so much for the invitation and that wonderful introduction. Excellent. You know what? I'm going to move this here. Can you all still hear me okay? All right, so today I'm here to talk to you about communication and antimicrobial stewardship. And I will start by saying I have no disclosures. So my talk today really has three objectives. The first is to establish a rationale for why focusing on communication in antimicrobial stewardship and the dynamics that underpin communication between antimicrobial stewards and prescribers is really critical. Then I want to explain attributes of effective communication in antimicrobial stewardship by reviewing results of a very large multi-site study that I recently completed. And then to present a shorthand way for you to approach communication and stewardship that aims to increase prescriber engagement and decrease conflict. And I will leave you with a shorthand way to think about it, which are the 3 Cs of communication and antimicrobial stewardship. But before I get into antibiotics at all, I did want to sort of start and set the stage for why in the world a sociologist is coming here to talk to you today, why a sociologist is hanging out with antimicrobial stewards and infection preventionists. And I really want to start with making a very broad point about the fact that the work that antimicrobial stewards, infection preventionists do is quality improvement, and that quality improvement involves fundamentally social change. And I want to talk about one particular infection prevention success story that I think really highlights this and really why we need to not only think about the sort of technical, tool-based things that we need to use to do our jobs, but also really take seriously the social dynamics, the social interactions that underpin what you're doing. And I want to start, so as I said, I'm a sociologist. I do qualitative research, which means that I spend time interviewing people, doing the work of infection prevention and stewardship, prescribers on the front lines, hospital executives, and throughout my talk today, I'm going to share excerpts of interviews that I've done over the course of the last decade to help me come to the conclusions that I'm presenting to you today. And so when I was doing my dissertation research over a decade ago, I was trying to determine a patient safety case to focus on. And I decided to do my research on infection prevention. And during the course of sort of figuring out why would this be a sociologic issue, I had an interview with an infection preventionist who said it very beautifully. So this is an IP who said, I went into this line of work because I was interested in infectious disease epidemiology and hospital outbreak investigation. I love statistics and the use of epidemiologic methods in infection control. When we see an uptick in MRSA in our ICU, I like to be a disease detective within my own hospital to figure out the source. And while all the tools I learned in public health school prepared me for that aspect of infection prevention, I didn't realize how much of it would be people management. So yes, our work is about microbiology, epidemiology, infectious diseases, and applying the best scientific evidence to control the spread of infection. But it's also about managing, cajoling, and sometimes nagging people to do the right thing every day when they come to work. My MPH coursework did not prepare me for a lot of that. So much of my job is trying to change hearts and minds, and I find that to be the most difficult thing. And of course, this, as a young graduate student in sociology, I was like, of course, this is the most sociologic thing in the world. And, you know, as I was doing this research, there was a really interesting sort of discussion that was going on about sort of infection prevention and really making sure that we attend to a variety of dynamics and drivers that shape success in this area. And particularly, I want to highlight one case study within infection prevention that I think of as kind of a cautionary tale of how when we read about success, that we make sure we take a holistic view and think about all of the things that perhaps went into that particular intervention working. And it gets down to this issue of ensuring that you don't confuse an adaptive problem with a technical one. And by the end of this little story, I will have made clear what that is. So many of you have probably spent a lot of time thinking about central line associated bloodstream infections. And this is a really interesting case study because CLABSIs, I think, are one of the earliest patient safety areas of focus, particularly in the United States, but really globally. And when you look at the patient safety social movement, particularly in this country, CLABSI prevention was an area of really intense focus, energy, and frankly, success in the early days of the patient safety social movement. And one of the sort of brightest spots in our sort of patient safety history were the results of this trial, the Keystone ICU study, which was led by a physician, Peter Pronovost, out of Hopkins, and they implemented an intervention in a network of ICUs across the entire state of Michigan to try to reduce CLABSI in their patients. It was successful. They reduced these infections. It was published in the New England Journal, and this was a study that generated a huge amount of enthusiasm, attention, and of course, efforts to replicate. And it even spilled out and over into the public discourse, into sort of normal everyday culture, not just the folks who are working on this. And the way that it was sort of metabolized in popular discourse is that it focused on one particular aspect of the Keystone ICU study, which was a central line insertion checklist. And so one of our sort of most luminous physician public talking heads, Atul Gawande, who's a surgeon, really got on the checklist train and wrote an article in the New Yorker with the headline, "The Checklist. If something so simple can transform intensive care, what else can it do?" He even wrote a whole book about it, right? But what is problematic about this is that when you take the lesson from the Keystone ICU study, that it was the central line insertion checklist that produced success, you are missing an entire other dimension of why that study worked, that if you just go and use the checklist, you are going to experience frustration and perhaps failure. And so my colleagues in sociology actually worked with Peter Pronovost to do what they called an ex post theorization of why the Keystone ICU study actually worked. And they were able to look at this network of hospitals and see the places that did well and did poorly, and also look at the project as a whole. And so if you just focus on the checklist, you are obscuring other really critical social mechanisms that led to change. And so first is engaged leadership. So the hospitals that did well had leadership that not only said, yes, we support your engagement in this program, but we're also going to give you some money to do this work, right? The ICUs working in this network where they actually got together at meetings just like this and interacted with each other, encouraged both learning, sharing, and something that in sociology we call institutional isomorphism in normal language is just keeping up with the Joneses. So the idea of if this hospital can do this or drive down their rates in this way, like, well, maybe we can try to do it, right? So the actual networking of ICUs in this study was a critical driver of success. They also creatively and used infection data to drive accountability. The data were transparent and really trying to use data to engage people in this work. There also was a wholesale sort of social reframing of what a CLABSI is. And this is something that in my later work in infection prevention I found to be true, that many of the critical care healthcare workers had sort of had this idea that, look, our patients come to us, they're really sick, some of them are dying, and we use this tool, these central lines, to save their lives. And so sometimes some of them are going to get infected. It's just the cost of doing business, right? But through this collaborative, through this work, they were actually able to reframe the definition of a CLABSI from the cost of doing business to mostly preventable harm that we should work to prevent, right? And that's an attitudinal shift, that if you are trying to change how something is done, the individuals involved have to believe that change is possible, important, and this is an attitudinal shift, right? And then finally, related to the actual checklist itself, the checklist is simply perhaps a piece of paper or a digital list. It's a tool, but it requires people to activate it. And very interestingly, hospitals that had great success in using the checklist actually had a climate where nurses, who were the ones who were in charge of keeping track of whether the line was inserted appropriately, that they felt empowered to speak up, usually to the physician, to say, look, you need to fix that drape, or you forgot to wash your hands, and stop the procedure to make sure that the proper process was followed, right? And that is completely about the social dynamics around the checklist. And so what we saw, and certainly Dr. Gawande has admitted this now, that if you just take away from this study that it was a checklist and you try to implement the checklist without paying attention to these factors, that you are going to fail to replicate its success across sites. And so I highlight this case because I really want to make it clear that, the social elements of the work that you do are absolutely just as important as your clinical knowledge, your IT knowledge, your data analytics skills, right? And Pronovost has really taken this message and written about it, and he's talked about this distinction between adaptive and technical problems or barriers that you may encounter when you're trying to do the very hard work of changing how clinical care is delivered in whatever domain: infection prevention, antimicrobial stewardship. And we tend to focus a lot of our effort on the technical areas that we know we're going to need to have to succeed. So we need the right equipment, the right tools, the right supplies. We need measures. We need data, right? We need to make sure we get data. We need to make sure it's trustworthy. We need to figure out how we're going to analyze it. We need evidence. We need guidelines and protocols about what the right thing is to do. And we need, of course, technology, right? And so these are, of course, really critical. But if we don't consider the fact that we also are going to have adaptive issues, this is what Pronovost calls adaptive issues, like local context and culture, emotions and psychology of the individuals whose behavior, again, you're trying to change, the social and political dynamics of the institutions you're working with. You might have 3 hospitals in one big city, and they all have completely different political dynamics, cultures, and histories. And those things matter when it comes time to implementing your work. And then, of course, what people believe to be important, their habits, and the things that they're loyal to. And so, as a sociologist, I empirically study healthcare organizations, hospitals, clinics, and I think of these sites as small societies because really, when you think about it, all the social interactions that sociologists are expert in are happening everywhere in our world, but they're also very much happening within the walls of our healthcare organizations because they are essentially the act of providing clinical care is people working together on sick people. And the social dynamics of that are very rich and critical and shaped by a number of social dynamics of groups that we as social scientists, it's our bread and butter. So conflict, status inequality and hierarchy, again, the sort of face-saving and emotion management that comes with providing clinical care. And we know, again, that these workplaces have distinct cultures and social dynamics that may shape what people do every day that really has nothing to do with applying biomedical knowledge, right? And so we need to just account for that. And so I start with this because I just really want to lay the groundwork for, I'm going to talk about stewardship and communication right now, but laying that groundwork for the importance of this aspect of your work is something I wanted to start with. And so when we think about why communication might be particularly important in antimicrobial stewardship, I think there are a number of reasons why this is a critical area to take seriously, both scientifically, but also to think about as you move forward in your work about how you can think about your own communication strategies in the work you do. And hopefully I'm going to be sharing with you some insights about how you can do that. And so when you look at the sort of core evidence-based recommended antimicrobial stewardship interventions that programs are trying to implement, they are absolutely focused on improving prescribing through communication, right? Whether it is prospective audit and feedback, prior authorization, or the newer handshake stewardship, the sort of in-person rounds where you're interacting with clinicians to give them recommendations about their stewardship. And it's been increasingly recognized within the antimicrobial stewardship policy community that stewards need more than proficiency in infectious diseases, micro, data analytics, informatics, that they also really need to possess social and communicative skills to implement change in complex organizations. And another reason why communication is important and frankly difficult in stewardship is because stewards are navigating really complex social and cultural dynamics in their daily work. When you really think about it, in a way, stewards are delivering advice to people who have not requested it. And that's awkward, right? They may play a restricting access and gatekeeping role, and that can sort of be perceived as introducing inefficiencies. They may be contending with what's been described in the literature as prescribing etiquette, or the norm of non-interference, that it's been reported that, sometimes people just don't like to be told how to prescribe antibiotics. And that can lead to a sort of dreaded label of the antibiotic police. And I wanted to present an excerpt of an interview that I did with a clinical pharmacist at a hospital who was commenting on their colleagues in ID pharmacy about sort of something they'd observed. And so this ICU pharmacist says, "I've noticed something when I've been rounding with the teams. So our ID pharmacists are part of the antimicrobial stewardship team and rotate on and off. One week they'll be doing stewardship, and the next week they're on service rounding with the team. And there'll be physicians that see these pharmacists rounding with the team, and they'll see them approaching, and they're like, oh no, what am I doing wrong? And the ID pharmacist says immediately, oh, I'm not doing stewardship. I'm on inpatient service. I'm not coming after you." Right? And this to me is fascinating because it demonstrates that even the steward has this awkward feeling of like, ugh, I'm the police of antibiotics. And so the other element of stewardship communication that is really critical from a social scientific perspective is that it's interprofessional. It's the same thing with infection prevention, that these communication is happening between individuals with different professional degrees, different degrees of authority and accountability, hierarchical dynamics around physicians, PharmDs, microbiologists, and that each group may have their own professional identity and subculture that is shaping their orientation to their work and what it means to be a good, quote, what, fill in the blank, good physician, good pharmacist, good microbiologist. And also really needing to recognize the strong emotional influences that come when it comes time to think about antibiotic prescribing, and that many clinicians talk about having a real strong emotional desire to use antibiotics even when there's no evidence they're needed just because they're afraid, right? And so stewards are dealing with that. So why does this matter? Why do these sort of communicative dimensions of stewardship matter? Well, the first, I think, has to do with the impact of all this effort, the impact of interventions, right? And so when you look at particularly prospective audit and feedback, where you're making a recommendation and the hope is that you're going to change the prescription to be more evidence-based, that in studies that have looked at rates of acceptance of these audit and feedback recommendations, there's a wide range in impact, right? So from 11% accepted to 90% accepted. The way you count that is complicated, as I'm learning currently in a project that I'm working on. But the point is that we also know some factors that are associated with whether your audit and feedback recommendations will be accepted, including the manner in which the recommendation is delivered. Is it face-to-face? Is it a note in the chart? The role of the steward and sort of the symmetry between the steward and the prescriber. Is it physician to physician, pharmacist to pharmacist, pharmacist to physician? The type of recommendation, recommendations to de-escalate are much more likely to be accepted than ones that recommend discontinuation. The sociodemographics of the steward, the gender of the steward, that's been demonstrated. And where the patient is in the hospital. Is it an ICU patient, an oncology patient, right? And so I also think that this is critically important when we think about the antimicrobial stewardship workforce and job satisfaction, right? That, when we think about communication as a core function of antimicrobial stewards, that this is something that you're doing every day, and that whether it goes well or whether it goes poorly can have an impact on whether the steward likes their job. And everyone is now talking about burnout, and when you actually look at the definition of occupational burnout, it includes three sort of dimensions. One, emotional exhaustion. Two, feelings of cynicism and detachment from work. And three, a sense of low personal accomplishment, that you're trying and you're just getting nowhere, right? And so when we think about stewardship as a bit Sisyphusian, we have here the pushing the rock up the hill of like you're continuing to try and the rock is rolling back on you, that is something that stewards can that they experience in the work that they do as a result of their communication experiences. And I think this is really critically important because of the workforce. If we have turnover of stewardship personnel, people leaving this domain of really critically important activity, we lose the relationships they've built, their institutional expertise. And, I was talking about this at a meeting, this is a while ago now, about sort of stewardship burnout. And a number of stewardship community members on Twitter were like, oh yes, burnout is real, right? So one stewardship pharmacist said, my first job after PGY2 was retrospective ASP. I felt like an antibiotic janitor. So another said, audit and feedback, no matter how well done, is offering people unsolicited advice with an implication they're currently doing it wrong. Kind of like telemarketers. The difference being that telemarketers don't usually care about their products, but that only gets you so far. Or my absolute favorite from Tristan Timbrook is, Sisyphus ain't got nothing on the IV to PO, right? And so this feeling that, we're doing all this work, but it is thankless, we are not getting anywhere. And to me, communication is at the heart of potentially why this is so frustrating. And so when we look at sort of the literature on communication and stewardship, it has been identified as important. We know it's important, but we lack an understanding of the attributes of what makes communication effective. So, and this is to set up a research study that I recently completed with these questions, right? So how stewards communicate, how do they navigate tension? How do they secure prescriber engagement? What are the microdynamics or the micro interactions that shape how these conversations, which are inherently kind of awkward and potentially emotionally charged, how they go? And I also, because communication takes 2, sometimes 3, even more, is how does the person receiving the message think about what they're hearing, right? And so how do prescribers think about the way that they are communicated with by their stewardship colleagues? What messages do they find to be credible, and how can trust be promoted? And so we recently finished a very large study that was intended to answer those questions. And with colleagues, this was when I was recently at the University of Pennsylvania, my colleagues there, Duke and Washington University in St. Louis, and it was a massive multi-site study. I won't go into too much detail on the data collection, but just suffice to say, we went to 10 hospitals across the country, and we spent time with stewards, we interviewed them, we interviewed prescribers, particularly prescribers that were in areas that have been identified as interacting quite a bit with stewardship. So hospitalists, ICU docs, pulmonology, surgery, oncology, neonatology, and general internal medicine. And we really wanted to take time and have conversations with them about what they thought about stewardship communication. And again, this has been a labor of love, quite a large project, as you'll be able to see in a moment. And I want to present to you the results, which we have summarized in our team down to the 3 Cs of stewardship communication. But to make the point that, this is something that we really spent time trying to learn from those in the field to try to identify sort of what are they doing and how is this received. Right, and so this is our prescribers. So we interviewed 146 prescribers across 10 institutions, and we were able to get some variation. We didn't want to just go to academic medical centers. We wanted to go to community hospitals, smaller places. We also included pediatrics. And as you can see, we had a nice representation from sort of core medical specialties that interact with stewardship. And so our first effort at analyzing these data was really to just sort of classify the sentiment of those that we included in this study towards antimicrobial stewardship interventions and stewardship communication. And we did something called sentiment coding, where we were classifying them as feeling negatively, mixed, or positively. And the good news is that, over half of the prescribers in our sample felt very positively towards stewardship communication, but we didn't have an insignificant amount that sort of were meh about stewardship, and then we had some real negative Nellies who were just did not like stewardship and were not afraid to tell us. But what's interesting is to really get at what sort of ideas or beliefs or experiences led to them sort of feeling this way about stewardship, and that's what I'm going to describe to you today. So first we'll start with the negative Nellies, so the negative perception. So what were some of the reasons why the prescribers that we interviewed, why did they feel negatively towards stewardship? Well, the first thing is that that many of these individuals really saw lumped stewardship within what are more unpalatable trends that they see sort of encroaching in medicine in a more broad sort of global sense, which is sort of the encroachment of bureaucracy and bureaucratic structures that sort of impedes on clinician autonomy. And in a lot of cases, it was about, profits being put over patients. And then, of course, everyone talked about the fear of cookbook medicine. And so here is a pulmonologist at a community hospital who was very clear about their feelings. Stewardship is emblematic of the way medical students are being trained today, and I think it's a very dangerous training. Everything is a cookbook, and at the end of an interview with a patient, if you've got all your cookbooks crossed in a computer, then whatever happens to the patient just happens. We were trained that we do everything we can to make a proper outcome, proper diagnosis using our thoughts. With the stewardship program, all of the doctors I talk to feel like you're given, if a person has pneumonia, you do this. You don't get to choose, you don't get to think, you don't get to do what you want to do, right? And this is an extreme case, right? And if you push this person to really say, like, is this really what's going on? But the point is that this attitude exists, right? And that stewardship, unfortunately, gets lumped into that. Another thing that we heard over and over again from those who felt negatively about stewardship is that stewardship is seen as a threat to the prescriber's professional identity and their sense of self, which really stem from two very, very human and normal things when you think about what people do to go through clinical training and then take care of sick patients every day is a real discomfort with being wrong and a feeling as if one's expertise is not acknowledged in the context of making the recommendation. And so here, a surgeon surgeons love to be interviewed and they love to say whatever, they're very frank. So this person said, we tend to be control freaks and we tend to be like, we're trained to be the captain of the ship. We're trained to make decisions and make our plan. That's part of our identity. And frankly, it feels awful when someone says, actually, your plan is terrible. And so you need stewards who can say that without actually saying your plan is terrible, right? It seems obvious, but sometimes we are thinking so much about sort of what's right and what's wrong, what makes sense based on the evidence, that we forget that there's a very human element to this. And then finally, those who felt negatively about stewardship really had a strong sense that the goals of their stewardship interactions, the goals of their stewardship program, were at odds with their goals as a prescriber, right? Either if it was like, I like the principle of stewardship, but they're so inefficient. They're interrupting me. I'm getting all these pages I have to call to get approval. Or there were beliefs amongst different clinical areas that sort of the principles of judicious antibiotic use were just incompatible with what they're trying to do. And that often came up in surgery, oncology, and neonatology, which is like, whew, that's a tricky social area. But here, an intensivist says, really explains, gets at this idea of goal misalignment. I feel like when physicians, not ASP, but in the critical care world, I feel like we're just trying to get these patients to the next day and keep them alive for the next day to keep going. So we play it minute by minute. We don't tend to look at the long term until the patients are kind of out of the woods. When we're putting on a broad spectrum antibiotic and want to keep it on for 7 to 14 days, but know we're going to have to get ID's blessing, I think that's where it becomes tense. When ASP is trying to make a recommendation based off their evidence base, and the physicians in the ICU are trying to make a recommendation based off just their experience and just trying to get the patient to the next day, right? And so this is two ideologies about, like, when people come to work, they have different immediate motivations, and that is something that is surrounding this communication that can make it feel like the goals are misaligned. So what about those who felt positively about stewardship? What underpinned these perceptions? Well, the first is a sense that stewards communicate things of value in a thoughtful and efficient manner. And things of value include education, updated evidence, and really a lot of prescribers talked about stewards, particularly the pharmacist stewards, catching errors or really demonstrating things of value. And so here's a hospitalist who says, the stewardship pharmacist here has good emotional intelligence. Our unit has a lot of high acuity and high stress. They're really good about fitting into a team, adding value. They come on rounds, but they also know when to pick the battle and when to have the discussion. And they're mature in their approach. So they know who the decision makers are, who pulls the levers, and how to educate. So they're really good about being total team players and making everyone learn something and feel good about rounds. They don't make people feel bad about what they don't know, so people really are not afraid to ask them anything. I mean, even the intensivists who've done this forever are pretty smart people. They'll constantly ask him, the steward, questions, right? And so this idea about not only, are you delivering things of value, but you're doing it in a way that has literally emotional and social intelligence about the context around the stewardship interaction. The other big thing that came across loud and clear from those who felt positively about stewardship communication was a sense that our stewards attempt to understand where we're coming from, right? That they are not aggressive in the way that they interact with us. They acknowledge my experience clinically, but also the knowledge that I might have a lot of interaction with this patient and their family that you may not have. And they think, again, critically about where and when to interject. And I think that, it can be, again, when we're like, we know what's right, this is what the evidence says, just do the right thing, that message doesn't always work because of all of these, again, social dynamics that are surrounding the interaction. And so this is a critical care nurse practitioner who was very interesting because they had worked at a previous place that this person felt very negatively about stewardship, but in their new hospital, they felt positively. And these are some of the greatest respondents. So this person says, I always think of antimicrobial stewardship and infection control in the same way. Like, those people, do they have hearts, But in my current hospital, the stewards definitely have hearts. At my previous institutions, they were curt. Well, why is this person on vanc? Stop. They were pushy, and it almost felt like a contest. They wanted to win. They come with their weapons. Here, we actually have a discussion. They let us explain our thinking, right? And this idea of a battle, of a contest, of a who's right and who's going to get to have the last word, right? We are trained in many of our clinical domains to know as much as we can and be right. It's like life or death, right? But the way that we communicate that with each other once we get into practice really requires that you don't think of this as a battle. And finally, again, relating to thinking about those who felt negatively, this idea of goal misalignment, those prescribers who felt positively said that they really got a sense that there was a shared sense of mission and motivation between the steward and the prescriber. And so this is a pulmonologist who can be some of the most critical of stewardship, who said, we're trying to help the patient. That's all. When the steward speaks to me in such a way that shows they're trying to help the patient, that they understand what my primary concern is, that they're on the same team as me versus they're a micromanager who's getting their bonus based on how little resources I use, that's why I feel positively about our stewards in a nutshell. So again, it's about sort of this sense of like, I'm reading your motivation in this interaction, and if I think you're just an arm of the bean counters, I'm not really interested in hearing what you have to say. But if it's about good patient care, excellent patient care, safety, that can come through in the message. So what did stewards tell us? Okay, so we interviewed almost 60 stewards, again, across these 10 hospitals. And they, luckily, and we analyze these data, and when we have all the data, we're analyzing it, and it's like, okay, there's some nice overlap and alignment. So the way that I'm going to frame what our stewards told us, I brought to bear a number of theories from communication science, but that when you looked across stewards, that their communication strategies really fell into sort of three categories: language, framing, and strategy. And I'm going to go over each. So first, as far as language, so stewards used, really in our interviews, went into great detail, and even we had a question like, can you walk us through a recent interaction you had? And they would verbatim talk about the words that they used. And what we found is that stewards who particularly felt confident about their communication were very purposeful in the words that they used, the way that they used certain terms and language, and they did that to try to reduce the defensive reaction that they had, that is part of this sort of innately awkward interaction. And that what we found is that the way that they talked about using language was a way to sort of adapt their intervention giving to this prescribing etiquette, right? The idea that people don't like to be told what to do, and so we need to find a way to tell them what to do without making them feel that way. And so here is a steward, a physician steward at an academic medical center who says, my approach has changed a little bit in that I try to be more of a, here's what I see is going on, not, I see you doing this, you need to stop it. I tend to use softer language, just because I'm not always right in what I see. I was somewhat dogmatic when I started this. My approach has shifted. It doesn't mean I've changed what I recommend. My approach has changed to be a little more collaborative. Here's what I see. Help me to understand. Explain to me why you're doing this. It appears you could do this. This would be more efficient. This would be more effective. This would be better for the patient. And my sense is people will respond better to that than me saying, what you're doing is not right. You need to stop doing this. People just stop listening when you're very dogmatic, especially surgical or ICU teams. When you're dogmatic with these clinicians, they tend to dig in and become dogmatic right back. And a lot of stewards that had been in practice for a long time talked about a transition from coming out of training being like, I know what's right and I'm going to convey what's right, to being like, okay, this needs to be a little bit of a give and take. Stewards also talked a lot about framing, and framing is a concept from communication theory that is kind of what it sounds like. It's like if you think about if you have a photograph and you put a picture frame on one part of the image, that's sort of the part of the image that you're emphasizing, right? And so frames can be thought of as the way that we sort of highlight the meaning of the essential nature of the content within the frame. And communication can be framed, right? And so what we heard from stewards was they had a lot of very strong feelings about this, that they always try to communicate that the ultimate goal of stewardship is patient care. They avoid discussion of finances, regulatory pressures, or assessments of medical knowledge. Now, finances, maybe if they're talking to the C-suite or people who care about that kind of thing, they will modify their messaging. But in general, it's about the patient. They also talked a lot about acknowledging in their messaging the prescriber's expertise and their level of responsibility. And they purposely talk about avoid adopting a conflict orientation. Like, I am not the antibiotic police. I'm not going into this as the police. If you feel sheepish, like, oh, I'm going to have to tell you what to do and I don't want to do that, that shapes how you have this interaction. And so this is one of my favorite explanations from a physician at a children's hospital who says, it's important to acknowledge the prescriber's expertise. If you come in as a super expert, that torpedoes the whole thing, because those people are practicing a craft just the same as we are. And if you come at it from a standpoint of, well, let me show you how it's done, then you're going to be miserable and they're not going to like you. Having the emotional intelligence to say, we're preparing to exert the Hawthorne effect on them, and nobody likes that. Nobody likes when mom comes over and checks to see how you're folding the underwear, She's probably not going to be like, oh, it's so great job. Have you thought about folding it this way? You're not there to second guess. You're there to understand and help them think through a problem, because you both have the same goal in mind, which is taking as good a care of that individual as possible. And then finally, strategy. And so this was a really critical insight that we heard from our stewards, that they don't think of these as one-off interactions. They think of their communication as unfolding over time, and that they believe in investing in future interactions. And that they do this by saying, well, I might not get what I want now, but this person might not be accepting my recommendation now, but in 2 weeks they may accept it. They talk about knowing which battles to fight and the importance of leaving some things on the table, and talk a lot about meeting prescribers where they're at, both physically if possible and sort of emotionally, and recognizing what might be going on around this individual. And they also try to not just be associated with antibiotic recommendations. So this is a physician who says, if you're showing up only when you're delivering bad news, essentially, or telling people that their particular approach is in needing of remediation, then they start to dread seeing you, like, oh, they're here because they're the police and we're bad. But if we come by and be like, everything's great most of the time, or hey, it looks like we don't have any specific questions for you, and then we can be a resource if they have a question, then it's more of a congenial relationship, and they get positive reinforcement and feel good about their stewardship. I think many people internalize the stewardship ideas, and they'll even start to talk about what they did. And so it's a way for us to reinforce their positive behavior instead of being a parent and only giving out punishments. We give a lot of positive reinforcement. And so what we really took away from this, the high-level summary, is that prescribers in our study generally felt favorably towards stewardship, and that communication that was viewed positively was not dogmatic or aggressive, conveyed a shared sense of mission, a desire to understand, and was seen as efficient and value-added. And that the stewards in our study really talked about being purposeful and multimodal about the way they thought about communication, and that it wasn't sort of just an afterthought, that they considered the language they used, they were very purposeful, the framing and the strategy, and they really cared a lot about how they built relationships as a way to establish credibility and legitimacy. And so there are some limitations, and I'm happy to take questions or talk at the break about the actual study itself. But how can we use these findings? So to really wrap this up and leave you with something hopefully that will be useful is, I think, acknowledging that communication and stewardship takes effort and is challenging, that you can approach it systematically, holistically, and with a consideration for the unique context in which you work. And as part of some of the work that we did, and this was actually during the pandemic when a colleague of mine in antimicrobial stewardship, all the medical students were not allowed to be in the hospital, and my ID colleague was like, hey, let's do an elective for med students, a virtual elective on stewardship. And hey, Julie, how would you help teach the med students about sort of how to think about what you do and about communication and stewardship? And we came up with a shorthand, because everything has to be shorthand, the 3 Ps, the 3 Ds, and the 3 Cs of stewardship. And so I won't go into too much detail on this table, but the 3 Ps and the 3 Ds are things that anybody in stewardship know are basic principles, right? So the place, the pathogen, the patient, the drug, the dose, and the duration. And the 3 Cs that I've added to this are context, communication, and collaboration. So just as much as you need to sort of be thinking about the culture results, the dosing, the history, of this patient, you also need to sort of think about the context around the interaction, the communication that you're going to use, and sort of thinking about collaboration, right? And so I'll be sharing a handout version of these slides, but the point is to think about these different dimensions of how you're going to communicate, what mode, who you're going to communicate with, and really the context around that interaction, the circumstances surrounding this individual that you're going to be interacting with, how are you going to sort of take into account the perspective of the other, and then really, thinking about collaboration. So this idea that an interaction is not a one-off. Interactions are chains that build up over time. It's part of relationship building, and it also is how we know how trust gets established. Trust is established through repeated interactions. You don't just come out the gate trusting someone. You have to have these interactions over time, and that's the bedrock of trust, right? And so thinking about the collaborative dimensions, and it's not just like, oh, I'm preparing to go tell someone that they have to stop using an antibiotic or what in the world, why are they doing this crazy thing? It's like taking a step back and acknowledging their context and how will whatever you're going to be communicating about build relationships in the future. And I think, it can be easy, and this just brings us back to the beginning of what I was talking about, to think about technical versus adaptive elements of quality improvement, right? And so if you think about stewardship from a technical perspective, right, it is the steward is getting a lot of information about what's going on with antimicrobials in their institution, and then they transfer that information about what's going on, what we recommend to the prescriber, right? That's information transfer. That's not communication. Communication is a wholly social and group dynamic, and it involves not only the steward and the prescriber and information moving back and forth, but also sort of taking into account these contextual features, but importantly also acknowledging the role of other people, not only other people in the stewardship program, but also other prescribers. And so people always ask me, I've got this one person who just hates me and hates everything I do in stewardship. What should I do? Well, maybe working on that person is not going to help, but if you can work with their colleagues or find somebody who that person trusts, that becomes an ally in your work. So I'm all set. I'm happy to take any questions. A few minutes left, so. Oh, hi, Raman.
Hey, how are you? It was a fantastic talk.
Oh, thanks.
Always an inspiration and also reaffirming for someone who does stewardship a lot. So I wanted to ask you, I think a lot of your focus has been on acute care and ICU.
Yeah.
What are your thoughts on trying to do this in other settings like outpatient or dialysis or long-term care?
Yeah, that's an excellent question. And so I think one of the key things has to do with the second C, context, right? And so thinking about context is not just sort of the work that's going on, but who are the people that are present? Who are the people that need to be engaged in the communication? And so we know that in outpatient settings and in sort of long-term care settings where perhaps there is more engagement, understandings and expectations from patients and their families, that they become a part of this as well, right? Or when you bring nursing more into the discussion. So I think you can really adapt this to any setting in which you're sort of preparing to try to influence behavior by sort of looking at the landscape and saying, what's unique about this area? And who's available to be communicated with. I think, yesterday I was talking to some people about, stewarding surgeons, right? And they don't maybe have rounds in the same, they may be meeting at 5 in the morning and they're in the OR all day. And so communication with them involves, finding them where they are. And the same thing in a long-term care facility where there may not be a physician on site, and who are you going to speak with? How do you get access to them? And really trying to learn the rhythms and the routines of that particular environment, as well as sort of who the players are, the stakeholders are. And again, patients and families become really critical in the acute setting. There's been an attempt to try to engage, but I think in general, it's really not as much of a focus as it is in outpatient and in long-term care. But that's exactly what I would recommend. Who the people are, where are they, what's their flow of work. So,
fantastic. And I also wanted to thank you for the idea of having people become their own stewards over time. Awesome, thanks.
Yep.
Thank you, Julie. That was really amazing. I am curious, as a stewardship pharmacist who in the past has had both negative and very positive interactions with individuals, when I think about the negative perceptions that you put into that you studied, and are there communication strategies in your professional expertise or opinion that can help to do those alignments of motivations and avoidance of medicine, et cetera? You kind of alluded to this at the very end when you mentioned, like, all right, go and find other people that are allies that can help. Are there other strategies that we can implement?
Yeah, I think part of it gets to, so it might seem odd to say that a important communication strategy is listening. So finding a way to understand and get at that individual's motivations, because it may be that they are, they were burned in the past and, they're terrified. It may be that they're just terrified that, or anxious that whatever it is that you're asking them to do is going to become inefficient and interrupt their workflow. It could be that they're cranky about other things and they just see you as another arm of bureaucracy that's coming to tell them what to do. So certainly leveraging allies who maybe are within their circle of influence is one way, but finding ways to hear them out. Sometimes people are just like, don't want to talk to you, but sometimes you can get in the door through like things that they need, like education, or be like, hey, you want to partner with me on this guideline revision? Or do you want to do this study with me? So finding ways to deliver something of value to get into the door, to have that conversation, and that listening and understanding is going to set the stage, and it will affect what you do next. And so I would say, and it can be very normal to say, this person doesn't like me, they are prickly, I never want to talk to them again, right? Which is fine and it's human, but like having that bravery to say, okay, let me try to understand what's going on here is going to set the stage down the line for some big wins. And some people I've talked to have just talked about like the crustiest, angriest person, and they were able to bring them over through persistence and those kinds of multi-layered strategies. And then it has a big impact because they train people, they set the stage. So that's what I would recommend, is listening as a key communication strategy.
Thank you.